Good morning to all of you. Well, this is the second session of the CPR which we discussed earlier on an adult individual. Today we are going to discuss the neonate or the pediatric version of CPR. It is called neonatal resuscitation. Now, what is the burden of the problem which we are going to face when we are dealing with a neonate or when we are dealing with a pediatric patient? First is birth asphyxia. 23% of 1 million neonatal deaths in India. Long-term neurological complications. Death. Neonatal resuscitation is simple, inexpensive, cost-effective method. The problem is NNR is often not initiated or it is incorrectly used of method. What are the successful NNR factors? Anticipation. Call a skilled person. Once you anticipate that this child after the bath may create problem, please do call a trained or a skilled person. Adequate preparation at the place of birth, accurate evaluation with the algorithm best, prompt initiation of the support services. Anticipation comes as high-risk delivery, maternal condition, advanced maternal age, diabetes mellitus, hypertension, previous history of stillbirth, previous history of fetal loss, early neonatal death. These comes as a maternal condition. Fetal condition comes as prematurity, post-maturity, congenital anomalies, multiple gestations, that is twin pregnancy, triplet, and so on. Antepartum complication comes at antepartum hemorrhage, oligo or polyhydramnios, either oligohydramnios or polyhydramnios. Delivery complications, malpresentation of baby, MSAF, instrumental delivery, antenatal asphyxia with abnormal fetal heart rate. Now, adequate preparation is required. Radiant warmer is to be turned off and the room should be heated. Oxygen source should be there with open and adequate tubings. Suction apparatus tested should be functioning properly. Laryngoscope should be functional with bright light. Resuscitation bag and mask demonstrate an adequate seal and generation of pressure. Now this is a picture of a radiant warmer. Now suction equipment. Bulb syringe, mechanical suction and tubing, suction catheters of 5 French, 6 French, 8 French, 10 French, or even up to 14 French. 8 French feeding tube and a 20 ml syringe and meconium aspirator. Bag and mask equipment, device for delivering positive pressure ventilation, capable of delivering 90 to 100% oxygen, face mask for newborn and premature sizes, oxygen source with flow meter, flow rate up to 10 liters per minute and tubing. Intubation equipment, laryngoscope with straight blades number 0 and number 1, extra bulb and batteries for laryngoscope, endotracheal tubes from 2.5 to 4 mm internal diameter, stellate, scissors, tape for secreting devices, alcohol sponges, CO2 detector or capnograph, laryngeal mask airway is optional. Now medication, what are the things required? Adrenaline or epinephrine, isotonic crystalloids, sodium bicarbonate 4.2%, naloxone hydrochloride, dextrose 10%, umbilical vessel, catheterization supplies, sterile gloves, scalpel, scissors, antiseptic solution, umbilical tape, umbilical catheters, syringes. Miscellaneous, what are the things required? Gloves and appropriate personal protection, radiant warmer or other heat source, firm padded resuscitation surface, cloth with second hand, warm linens, stethoscope, tape, half or 3/4 inches, cardiac monitor electrodes for pulse oximeter and probe for delivery of oropharyngeal airway. For very preterm babies, compressed air source, oxygen blender to mix oxygen and compressed air, pulse oximeter and probe, reclosable food-graded plastic bag or plastic wrap, chemically activated warming pad, transport incubator to maintain for baby's temperature during its move to the nursery. Now, successful NNR factors: anticipation, adequate preparation, adequate algorithm, and prompt initial support. Now we are coming to accurate evaluation. Evaluation algorithm best: rapid assessment of neonatal clinical status. Is the infant full term? Is the infant breathing or crying? Does the infant has a good muscle tone? If yes, no resuscitation. If no, then definitely resuscitation is required. Rapid assessment: term gestation, crying or breathing, good muscle tone. Initial steps is stabilization. If it is no, start ventilation, chest compression, administration of epinephrine and a volume expander like IV fluids. And initial steps: provide warm, clear airway. If necessary, keep the baby dry and stimulate. Breathing or ventilation to be started. Chest compression, the circulation is started properly. Administration of drugs or volume expansion. Provide warmth. Head position is in a sniffing position, clearing the airway. If necessary, drying the baby. Tactile stimulation for breathing. These are the head position for neonatal resuscitation. The first one is correct. This one and this one incorrect. Well, this is the AAP algorithm. One should remember this clearly and one should go as per this. This is, in short, the AAP algorithm. What we have to do at birth, at 30 seconds, at 60 seconds. Progression to the next step: respiration and heart rate. If it is apnea, gasping, labored or unlabored, and if the heart rate is less than 100 beats per minute. Form of assisted ventilation is needed when there is no improvement in heart rate. Also assess chest wall movements. Should be delivered at a rate of 40 to 60 breaths minimum. Maintain heart rate more than 100 per minute. Goal of PPV: assisted ventilation should be delivered at a rate of 40 to 60 breaths per minute to promptly achieve or maintain a heart rate of 100 per minute. Bag and mask ventilation: this is the way it should do. This is the easy clamp technique. Endotracheal tube: when the chest compressions are performed, initial endotracheal suctioning for non-vigorous meconium stained newborn. These are the endotracheal tubes. These are the sizes. Laryngeal mask airway is soft mask, fits over the laryngeal inlet. When inflated, occludes esophageal opening. Done when BAP is unsuccessful and tracheal intubation is unsuccessful or not feasible. These are the laryngeal mask airway pictures. This is a targeted SpO2 after bath. After 10 minutes, it should be 90%. If it is 60 to 65 minutes at birth. Simultaneously assess heart rate, respiration, oxygenation. Initial steps in resuscitation followed by PPV. This is the AP algorithm again. Chest compressions started with heart rate is less than 60 per minute despite adequate ventilation with 100% oxygen for 30 seconds. Delivered at lower third of the sternum to depth of 1/3 of the epidiameter of the chest. Techniques: 2 thumb encircling hands technique, compression with 2 fingers, second hand supporting the back. 3:1 ratio. 30 compression to 30 ventilation to 90 compressions. This is the way it should be given. This is another technique. So you've seen what is the chest compression. Most sensitive indicator of a successful response to each step is increase in the heart rate. This is very important. Now we are coming back to the LP algorithm again. Now medications are rarely indicated. Most important step to treat bradycardia is establishing adequate ventilation. Heart rate remains less than 60 despite adequate ventilation. Endotracheal intubation with 100% oxygen and chest compression, then we can use adrenaline or epinephrine or volume expansion or both. Epinephrine, route of administration intravenous, recommended dose 0.1 to 0.03 milligram per kg per dose. Desired concentration 1:10,000. Volume expansion when required. Suspected or known blood loss, isotonic crystalloid solution, normal saline, blood, dose calculation 10 ml per kg. Assess if resuscitation is needed, keep warm position, clear dry stimulation, give oxygen as necessary. Positive pressure ventilation is a must, endotracheal intubation if required, chest compression if necessary, followed by drugs. Golden minute, less than 30 seconds. Warm, keep the patient dry, clear airway if necessary, and stimulate. 60 to 30 seconds. Assess two vital characteristics, respiration and heart rate. Golden minute project skill-based training. This is the golden minute algorithm. Post-resuscitation care needed for those who require PPV at risk of deterioration, hypothermia should be prevented. Hypoglycemia should be looked into. CNS complications, apnea, pulmonary complications, pneumonia and hypertension need to be evaluated. Need monitoring and evaluation. NICU admission may be necessary. NNR not indicated conditions with clearly early death, extreme prematurity, gestation period less than 23 weeks, mark this. Birth weight less than 400, anencephaly and chromosomal abnormality, trisomy 3. Here we should not initiate NNR. NNR nearly always indicated for high rate of survival, acceptable mortality and gestation age more than 25 weeks. Those with most congenital malformation. NNR conditions associated with uncertain prognosis where the survival is borderline. Parental desires concerning initiation or resuscitation should be supported. Discontinuing resuscitation efforts, newborn with no detectable heart rate, consider stopping of NNR if the heart rate remains unpredictable for 10 minutes. Summary. Most infants transfer from intrauterine to extrauterine life. 10% need some intervention. 1% need extensive resuscitation. Anticipate the need for NNR. Adequately prepare for NNR. Evaluate the newborn as per AHA-AP guidelines and follow the recommended protocol. There will be certain MCQs which will be given to you. You can take your time and answer that. Thank you.